Okay, at the outset, I would like to thank Dr. Madhu and Dr. Ramanraj Garu. Ramanraj Garu is my, what I say, close friend during his IVL fellowship days. Actually, at Ali Prasad Institute, we used to roam around for the breakfast classes and then all the trainings and whatever help is required and all. Madhu, you have seen his photograph in Aravind, right? But I know him at that age. And I started inspiring him for the ophthalmology. And at each stage, means I observed him, and he has grown by miles, actually. And I was inspiring and telling him, encouraging him to contest for member scientific committee, actually, in All India Ophthalmological Society for last, how many years, Madhu? 10, 15 years, I told him that you should be scientific committee. And today you see this hall, I say why he should not be a member scientific committee at AOS level. And from Andhra Pradesh, he is standing and we are not supporting him will not be a justice. Madhu, I vouch that everyone should vote for you. Find your name in the list of 35 members of member scientific committee, and another secret I will tell you later on, okay? How to handle the election. Yeah. And diabetic retinopathy is very close to my heart, okay? And when I suggested him diabetic retinopathy as the session, he said, will it be a master class? I asked one question to the audience, how many of you are diabetics? Raise your hands, because you may hesitate, but yeah. Let us go to the first slide. If you see, 8 out of 10, almost 11% of the population means are diabetics, and another 40% of the diabetics, they don't know they were diabetics. That is another big mystery. And this is likely to increase. It is not by family history. It is mainly by the urbanization, and now the age of the population is also increasing, and decreased level of physical activity. Many people don't do exercises, walking and all. And Majji Pradesh, we'll say body, middle of the body, waist level, like Rajesh is patting his tummy. If it is increases, then the risk of diabetes can increase. And over 20 years, there is a lot of increase in the prevalence of diabetes across the globe. And China is leading country, but India is not far behind. And about the non-modifiable risk factors like duration of diabetes, type of diabetes, and pregnancy, there are modifiable risk factors which are very, very essential. In that, tight control of blood sugar, hypertension, because the level of decrease in the complications with tight control of diabetes is almost 75% reduction. And in hypertension, it is almost 30% reduction, which are very, very significant. In addition, hyperlipidemia and obesity should also be addressed. Again, if you see greater insight in diabetes, the proliferative diabetic retinopathy have a list of modifiable risk factors. CME have a different kind of modifiable risk factors. And ocular surgery means the patients who can need vitrectomy has a different modifiable risk factors. This need to be observed. So here, after I will show some photographs, which are very, very clear in this thing. So you should be able to at least, human eyes is much more better resolution than these cameras. Only problem is we don't apply in the clinic. If you apply, Then you can find out what are the microaneurysms here. You can see the red dots here. So you cannot miss diabetic retinopathy in its early stages. And once it is in mild and moderate non-proliferative diabetic retinopathy, you should not leave this patient. You should have more frequent follow-ups. And here, can anyone say what are these? This is the early diabetic macular edema, which may become significant macular edema. So once diabetic macular edema occurs, you should know what type of diabetic macular edema it is, because it can be mild, moderate, or severe. I am just presenting you this slide, which is very important for diabetic macular edema, where I have shown you a picture where there is mild non-proliferative diabetic retinopathy but no macular edema. Here it is moderate diabetic macular edema, which is non-involving the center but exudates approaching towards the center. And this is a diffuse diabetic macular edema, which is very severe condition in terms of diabetic maculopathy. So this is the algorithm for managing diabetic macular edema. This is a general ophthalmology topic. It is not a retina specialist topic, 100%. So in your clinic, you need to identify which are the diabetics which need to be treated by you or followed by you, and which are the patients which need to be referred to the medical retina or retina specialist. So in diabetic macular edema, you ask yourself 3 questions. One is center involving, non-central involving. Second question, whether there is a vitreomacular traction or no vitreomacular traction. Third, whether the diabetic macular edema is significant enough for you to treat and which is affecting the vision. Okay? So if you see here, center involving macular edema, non-center involving macular edema, focal or grid laser is the primary line of treatment. So don't try to inject when it is non-center involving macular edema and there are only sarsenate rings. Go for photocoagulation. The second is center involving macular edema. Again, you need to identify whether there is VMT, vitreomacular traction, is there or not. If vitreomacular traction means OCT, you need to do and confirm it. And if it is there, surgery is the answer, not the injections. Many people are unfortunately thinking that injection is easy and we can go for irrelevantly in any case, which is only cost the patient a ton of money. Let us save that money. The third one is the focal or diffuse leakage, which requires anti-VEGF injections, which you need to be very, very careful in choosing the anti-VEGF injections. And this is one study where different agents were compared, and when the vision is 20/20, then all the agents are good, but when it is vision is 20/50 or worse, probably aflibercept was good in this study. And diffuse diabetic macular edema is a special entity where you need to work on the systemic status, because many of these patients have a deranged systemic status. So you need to address systemic status while treating or even before initiating treating. I would suggest simultaneously treat, but if you hold treatment for some time, then the patient will understand what is the importance of controlling the systemic status. Otherwise, he will not. And you will also not able to convince him. Then we go particularly onto the non-proliferative and proliferative diabetic retinopathy. Staging is required. Staging I have not given much importance, because non-proliferative, you may think that it is no treatment is required, you will send back. It is not so. You see very severe non-proliferative diabetic retinopathy, within 1 year they will get converted to proliferative diabetic retinopathy. And within 5 years, almost 70%. So these patients require very rigorous follow-up. If you think the patient cannot follow with you very frequently, then you may have to commit for pan-retinal photocoagulation. That is very, very essential. So I'm showing you some of these photographs where early proliferative diabetic retinopathy means any neovascularization of the retina, which is very small, may not be causing any hemorrhage or anything, but this means you need to commit for laser photocoagulation. Those studies have showed repeated anti-VEGF injections reduces the proliferative diabetic retinopathy risk. Over 5 to 7 injections may be required. Only danger is that if these patients do not follow regularly, these anti-VEGFs there can be a rebound proliferation of neovascularization and worsening of proliferative diabetic retinopathy. And when there is a hemorrhage, then it will be called high risk, and you should not delay the laser photocoagulation. And in high-risk proliferative diabetic retinopathy, another component is the traction. If you say single traction is there with vitreous over to the disc, this usually, even if stable diabetic retinopathy status, it may not cause bleeding, but certain times you need to educate the patient not to have any vigorous movements. Otherwise, these patients had a bleed because of the cough, jerks. This can happen, and if it gets repeated, then a surgery is required. And there are several conditions along with diabetic retinopathy which can mimic diabetic retinopathy, like here chronic myeloid leukemia is one. This patient is having both eyes involved severely, and it almost mimics like a severe non-proliferative or early proliferative diabetic retinopathy. And hypertensive retinopathy, this was also diagnosed as non-proliferative and proliferative diabetic retinopathy, but it is a pure hypertensive retinopathy where the OCT here, it's showing the subfoveal fluid. And the management of hypertension is the mainstay, not pan-retinal photocoagulation here. It may worsen the clinical situation. And PDR management at different levels are there depending upon the severity of the proliferative diabetic retinopathy. First and foremost is the early proliferative diabetic retinopathy. Definitely laser will give you long-lasting treatment, definitive treatment, though anti-VEGFs have given you, the studies have given you that it may play a role. So this case is a, sir. This case is a stable laser proliferative diabetic retinopathy. Means ophthalmologist has a role in identifying whether the treated patient is stable or not. That's where you can play a big role. However, you need to identify which patient requires a supplemental laser or repeat this thing. If you see here, there is a neovascularization. Such patient, though it is seemingly adequately treated, it requires supplemental laser so that stabilization will happen and there will not be any bleeding. Here on, I will show some results of surgery. Again, pre and post-operative fundus appearances, which show that we can clear any number of proliferative processes in diabetic retinopathy. This is one such patient where there is severe proliferation, which is very clear here, which will give you a stable visual status post-operatively for a long term. This is another proliferative process, which is almost encroaching into the macular area with poor vision, stabilized after vitrectomy. Very severe proliferative diabetic retinopathies, you will see the proliferation is so much, it is very hard to believe for you people to happen that this can be cleared. But you need to understand, over the years, last 30 years I am doing the same work to master the art of clearing any amount of fibrosis. So that should not go waste. So we should give a try for that. And this patient, see the result. Can you see any membranes? This is all because of the effort. Again, another severe membranes. Cleared to an extent, and this is post-operative. Certain times, some membranes can remain this reoperated and good visual acuity. And here, preoperative severe. This is post-operative done elsewhere, and again we have stabilized it. This is very severe membranes in the macular area, which were after the post-operative. You are not seeing any trace of membranes here. This will give a long-lasting result. So we are coming to the end of the presentation. It's mainly the timing of dilated ophthalmic examination. One should remember what is the age of the patient when they have presented, when you have to really see the first examination. Then once the severity of the diabetic retinopathy, how frequently should we follow? These patients should not be left for one single time examination. And these are all the risk factors that can result in poor visual acuity. Okay? With this, I'm almost coming to the end. It's not coming. Click. This is my Yashoda branch, because many of the people are asking where you are working. It is in the high-tech city, and this is ultra-modern hospital. It is quaternary care hospital with all good specialties. We can address very well all the requirements of the patients, especially end-stage patients like diabetics with multi-system involvements. So it is very essential. Thank you for your attention.
Dr. PLN Raju sir, please come on to the dais and give memento to Dr.
You want
Ajit.
to ask one question? Yeah.
Okay, sir.
See, it is a combined responsibility. In a family, no one should think family head is the whole responsible. Every member is responsible. Similarly, diabetic retinopathy management is responsibility of the anterior segment surgeons, comprehensive ophthalmologists, medical retina, and surgical retina specialists. It is not one man's play. अरे भाई मैं कौन हूँ परमिशन देने के लिए Mike, come here.
Anti-VEGF is being given by all anterior segment surgeons, posterior segment surgeons. I one request is, first thing, as sir told, please confirm that there is no epiretinal membrane before starting injecting anti-VEGFs in macular edema. Yeah, that point star has told. And please don't inject anti-VEGF when you have fibrovascular proliferations, because we are seeing very tough traction retinal detachment. Surgical prognosis is also becoming bad. And one main important request is, please do pan-retinal photocoagulation after injecting 1 or 2 injections, because in Arogyasri, 6 injections are covered, 3 injections given in one eye, 3 injections given in one eye, and patient disappears for 6 to 8 months and presents with bilateral traction retinal detachment. So don't let the patient lose the vision because of that. If you are not doing pan-retinal photocoagulation, get the pan-retinal photocoagulation done after injecting anti-VEGF. These 3 points I want to tell.
Don't take me wrong. Our intelligent juniors, some of the juniors, I am saying, they are not ready to do pan-retinal photocoagulation because it takes half an hour. They want to give injection because it is 1 minute procedure. I'm sorry to say that.
Dr. PLN Raju sir, please. వెళ్ళిపోయినట్టున్నారు. మళ్ళీ వెంకటేష్.